pleasure to be here. So that decision to leave Big Blue for a little risky startup may be a reflection on the quality of my judgment that remains to be seen. So I'm going to be talking about, I think, kind of put some things together that you've been hearing today. You've heard a couple of speakers talk about problems with healthcare, or some signs that we're not doing as good a job as we should. There was an article published about a couple of years ago about healthcare in the United States that estimated that on average, 1/3 of what's spent on healthcare in the United States is for things of no value. Okay. The United States is perilously close to spending $3 trillion a year on healthcare. That means somewhere $900 billion to $1 trillion of waste. Okay. Not a very good way to run a system where 1/3 is useless. And some of this is intentional waste, like fraud, but a lot of it is overtreatment, giving treatment that can't possibly be helpful. A lot of it is failure to implement treatment that would be good, and some of you simply don't know, and you're taking slingshots. This patient's diabetic, I'll try this, it doesn't work, I'll try something else, it doesn't work, I'll try something else. The net result is we're spending a huge amount of money on things that don't work. So the lessons from this that have come down to health policy people and some practitioners and people who want to change the system is we have to do a couple of things. One is we have to make better decisions. We're making really bad decisions if we're wasting 1/3 of everything we spend. And the way we have made decisions up until now hasn't been very good, hasn't been very efficient, hasn't been very helpful. We need to change the paradigm and start looking at people. Personalized healthcare, making personalized decisions. And we've heard several discussions about that today. Now, the idea of personalized healthcare is not new. Despite, if you listen to people in the genomics industry, they just invented it last year. It's been around for nearly 50 years, at least. So the first article I ever read the term personalized healthcare was in this article in the New England Journal of Medicine, July 4th, 1968. I remember the date because that was the year I started medical school. Talked about individualized medicine, personalized healthcare. That was the goal, to learn enough about the patient that you can make decisions that are more likely to be beneficial for that particular patient. The ultimate goal. The problem was we couldn't do it back then. We had no ability to collect enough information to really understand this patient, and whatever information we had was in paper records, and you might have 3 or 4 meters of paper records on an individual patient, no ability to analyze it to learn what we needed to do. So that was the goal, but we couldn't do it. So the way we made decisions, the traditional way we have made decisions for decades, maybe hundreds of years, is based on what was the gold standard of healthcare research, the randomized controlled study, the scientific method. You come up with your null hypothesis. My null hypothesis is that treatment A will not be better than treatment B. I grab a treatment group, I get a control group, I get some researchers, I have a solid firewall, so it's clearly double-blinded, and I test it, and I get the information that, in fact, with this treatment, group A did better than a different treatment in group B. And we based all our decisions on that kind of information. So if I had a patient with the disease that was studied in this article, I would try the treatment that were for treatment A, but it might or might not work. And one of the problems was these studies don't tell you anything about an individual patient. They tell you about a relative change between 2 groups. So in the group A that did better than group B, there are undoubtedly a lot of patients who did worse than other patients, and undoubtedly a lot of patients who did a lot better than the average. So it doesn't tell me anything about the individual, and if I'm making a decision about an individual, that's really what I need to know, is what information do I need to know to make a decision for this patient. And the fact that we relied on these so-called controlled studies, which were done in an artificial environment anyway, and had nothing to do with the real world, is one of the things that leads to a lot of the inefficiency in healthcare. At least that is my claim. Now, in addition to that, this gold standard of research ain't all that gold. There's a lot of research out there that shows these studies are flawed, to the point where in some of these reviews, the overwhelming majority of these studies are flawed and cannot be repeated. So what we treated as our guiding light, as our lodestar, not only didn't help us with individual patients, but was flawed at its foundation. So we need to move on to new ways of thinking about things and getting information. So what do we need to do if I'm going to learn something about a patient? If I'm going to learn about you, enough about you to make a better decision for you, I've got to work in the real world. Because that's where you live. You don't live in a controlled study. You live in the real world. That's where the idea of big data comes in. And many reputable research organizations, including the NIH and the United States, have recognized this. Okay. There's data out there on millions and millions of patients. Real world data, longitudinal data, new data, all out there. And if it's accessible to me, I can learn a lot. Okay. What's another limitation of the randomized controlled study? Okay. You read a randomized controlled study about CHF, congestive heart failure, and you try to apply that to a patient with congestive heart failure. Those of you who are clinicians, how many of you have patients with congestive heart failure that only have congestive heart failure? Okay. They'll have diabetes. They'll have COPD. Okay. How many articles have you ever read in a controlled study about a patient with CHF and COPD and diabetes? I would venture to say none. So let's take a simple case. You have a patient with coronary artery disease and asthma. Difficult to manage because the treatments for the two of them are antithetical. You want to give the beta blocker to the patient with coronary artery disease, that's going to make the asthma worse. You want to give a sympathomimetic to the patient with asthma, that's going to make the symptoms of coronary artery disease worse. So you cannot optimize the care of this patient by optimizing the individual diseases. But you can't find any research in these publications to help you understand that. So the only way to do that is real data. Big data, looking at data for lots of patients. So if I could get data, say, on 8 million patients, such as exist in the Kaiser Health system in the United States, or all the records for all the patients in National Health Service, I could undoubtedly find a cohort of patients with coronary artery disease and asthma in the real world, with years of information about how they have done and how they've responded to treatment. And looking at that, I could gain insight or inferences that would help me make a better decision about the patient in front of me with coronary artery disease and asthma. So we need to get away from these controlled studies and start looking at patients in the real world. So what can that tell us? Okay. Since we won't ever find any focused disease on these multiply complex patients, we need to work in the real world. There's some challenges with that. We don't have the controls that we're used to. Okay. We may see associations that have no real meaning. They're just random associations, but they give us some insight to help us make these decisions in the only way we can by using experience of patients that are very similar to our patients. So all this falls under the rubric of clinical decision support. We really want to make better decisions, but we recognize we need help to make those better decisions. Okay. Now, some people argue that these kind of analytics should make the decisions for the doctors. There's some reference to some things being better than doctors fairly consistently. And there's some people out there who argue that doctors should be replaced by computers to make those better decisions. It may be my ego as a physician, despite being an engineer, that I don't go along with that. But I've had debates with some people that do believe that computers should replace physicians. One of them is a fairly well-known venture capitalist entrepreneur, Vinod Khosla, who has argued that in the future he wants to be managed by algorithm, not by people. We've had this debate. Some people say he just has to be provocative. I'm not sure. I think he may have some belief. But the best response I've heard to that kind of allegation was Professor Warner Slack from Harvard, who, when asked, will computers replace physicians, his response is, any physician that could be replaced by a computer should be. Okay. Okay. So if we're in clinical decision support, and I mean by support, we want to make better decisions. I want to use all the tools available to me to help me make better decisions, for the patient and I together make better decisions. It has to be personalized. Again, 50-year-old idea, but to be personalized, because if we're going to be really effective, I need to make a better decision for you. Our ultimate goal is prevention. Yeah, how much better would it be if I could prevent you from developing congestive heart failure rather than treating you after you get it? But if we want prevention to be both effective clinically and economically, then we need to have a component of big data prediction. Okay, how really at risk for congestive heart failure are you, and what do I really need to do to prevent you from developing congestive heart failure and not use a one-size-fits-all? To do prediction, we need to look at patterns. Now, probably all decision makers, all experienced decision makers, use a form of pattern recognition. It's probably a proxy for experience. So when I was practicing emergency medicine, after well into my career, say 20 of my 30 years, after 20 of my 30 years, I could walk into a room, ask a couple of questions, and I immediately knew what was going on. I had been there before, whereas the junior resident with me might have to spend twice as much time and ask 20 questions. The interesting part about big data is that there are patterns in that data and the interplay amongst the different data streams that have predictive power that are beyond our ability as humans to understand. So we're taking this to new patterns, looking at those changes that a sophisticated computer system can identify to help us that we might not be able to identify it itself. And then the fifth P as a requirement for clinical decision support is persistence, because there's a lot of reasons why this is not going to work. It's new, it's innovative, it's challenging, it's threatening where things stand. So one of the challenges is turf battles over the data. Whose data is more important? Okay. Some of the genomics people think they are going to define healthcare for the future. You need to know nothing else. Okay. I don't think that's true. It's all the data we want to use. I really don't care who thinks their data is more important or which data is more important. All of it is going to be needed. So we've got to break through these turf battles and accept that we need everything out there. There's no such thing as too much data or the wrong kinds of data, because we don't know which is going to be powerful enough. Then another concept is called de-innovation, the reluctance to change what you're doing, even when it's proven that it's not as good as the new thing coming on. There are a lot of reasons for that. You don't want to be the first person to try something, because even though it may be proven, your peers may think of you as a little off the wall or too pushy or making them look bad. And there's another form of de-innovation reluctance that I've seen in big companies. I won't specifically say the big company I worked for, but in big companies. Okay. And that is, you come up with a fantastic new technology, but then you throttle it by keeping it under the wraps of your old style management, not open to the innovation and change that you need. And one of the differences I have found in this small startup is we don't have those problems like that. We can think and act quickly. So what are the characteristics of big data that make it threatening, make it sort of induce this reluctance to innovate? One is simply the amount of data. It can be an overwhelming amount. That's not a big technology challenge, but it's a challenge. The velocity of data, it's expanding. Brad was talking about the genomics data, how much more of it is coming at us all the time. The variety of data, all the different kinds of data, a challenge to kind of assimilate all that. And one of probably the major challenges is the fourth V, which is sometimes called variability or value or veracity. The fact that when you collect lots of data, a lot of it is wrong. It's crap. It's inconsistent. But part of the healthcare record says the patient's allergic to penicillin. Another part of the record said the patient successfully got penicillin. The blood pressure monitor in the ICU says that the pulse rate is 60. The oxygen monitor says it's 120 because it counts on two peaks. You have a lot of flawed data. People say, I'm going to wait until we get clean data. It's not going to happen in healthcare. Okay, there's some estimates that more than half of the data we collect in these big data efforts is flawed or inconsistent. So we need to learn to deal with it, that a lot of this data is going to be flawed or incorrect. And when we try to look for patterns and model this data, we're going to get some patterns or models or predictions that are simply absolutely wrong. Nate Silver, who is a big data analyst and wrote the book called The Signal and the Noise. When we get into this situation, we wind up modeling noise rather than signal. And so what he concludes from that is we can't rely on these models to do all the work for us. We need a combination of these powerful models and the domain experts to sift through those associations, those predictions, those inferences, to try to determine which ones are actually valid. So how is using big data different from what we've been doing up until now? Using new data sources and a new kind of thinking called inductive reasoning. When we did these randomized controlled studies with the null hypothesis, traditional scientific method, it's deductive reasoning. You come up with a hypothesis and then you deduce whether it's valid or invalid. here in big data, we look for the associations and then induce whether any of them are valid or useful, or they require further study. So we're getting lots of associations, and one of the advantages here that's coupled with the disadvantage is when you do a randomized controlled study, your null hypothesis is limited to something you can think about. So there may be important associations or insights out there that you will never come across if you stay with this primary deductive methodology. So we get into something new. Learn from daily experience. It's real world where patients actually live. Critically important. You can only deal with individuals on that kind of basis if you're dealing in the real world where they live. There's limitations I kind of referred to. You get too many associations. A lot of them may be nonsense. One of the social limitations of big data is the hype. If you read lots of articles, the New York Times, the Atlantic Magazine, how important big data is and it's going to transform the world. We have to be careful of that hype. So where can this work? Well, we have lots of problems in healthcare, like the top 5% of healthcare consumers chew up 50% of the healthcare cost. Using data to learn about those patients to make improvements in the way they're managed, to reduce avoidable hospitalizations, are something we can only do with big data. If you have patients with multiple chronic diseases, we're not going to find that information in randomized controlled study. We can only do that in big data. So if we put all that all together, my prediction for the future of healthcare research is that the role of this randomized controlled study is going to become progressively less important. I believe it's going to be relegated to only measuring our performance, not to give us new ideas or clinical decision support for treatment, being a fundamental change. So the New England Journal of Medicine, the British Medical Journal in 10 years is going to look very different. That is my prediction. It may be nonsense, along with all the other big data things. I'll leave it up to you to decide, but since a lot of my ideas tend to be somewhat iconoclastic, I take with some comfort a quote from Albert Einstein when people challenge me. Thank you.